Hello, my name is Nicole Sobis. I am a P2 student at the College School of Pharmacy, and I am going to be presenting my journal club today on the efficacy and safety of dulaglutide 3 milligrams and 4.5 milligrams versus dulaglutide 1.5 milligrams in metformin-treated patients with type 2 diabetes in a randomized controlled trial, the Award 11 study. I chose this article because at the time we were learning about diabetes in our PT course, and I also have family members that have been diagnosed with type 2 diabetes. So I wanted to learn a little bit more about the new treatment options that are available to those patients. This article was published in the Journal of Diabetes Care in March of 2021. The primary objective of this study was to evaluate the efficacy and safety of three different strains of dulaglutide, a glucagon-like peptide 1 receptor agonist, in reducing HbA1c levels from baseline to 36 weeks. The primary efficacy measure was the percent change in HbA1c levels from baseline after 36 weeks of treatment with dulaglutide. The secondary efficacy measures that are pertinent to this study are changes in body weight from baseline after 36 weeks of treatment with dulaglutide and the percentage of participants achieving an HbA1c level of less than 7%. The study was a phase 3 randomized double-blind parallel arm superiority study, and subjects were patients aged 18 and older with type 2 diabetes mellitus. Inclusion criteria for the study were patients that had type 2 diabetes mellitus for at least 6 months, have been treated with metformin on a stable dose for at least 3 months, had an HbA1c level of greater than or equal to 7% and less than or equal to 11% at study entry, and have a body mass index of greater than or equal to 25 kilograms per meter squared. Some inclusion or exclusion criteria included type 1 diabetes, having used any GLP-1 receptor agonist or insulin, which did not include prior short-term insulin use, which was categorized as insulin use less than or equal to 14 days, or have been taking any other medications for diabetes, excluding metformin during the last 3 months. There is more exclusion criteria listed in the handout provided. The study included 3 periods. There was a 2-week lead-in period, which was followed by a 52-week treatment period, with the primary efficacy endpoint being at 36 weeks, and a 4-week safety follow-up period. For the primary efficacy measure, patients' HbA1c levels were assessed at baseline, at 36 weeks, and at 52 weeks. For the secondary efficacy measure of the proportion of patients obtaining an HbA1c of less than 7%, levels were obtained at 36 weeks. And for the secondary efficacy measure of change from baseline and weight, measurements were obtained at 36 weeks as well. Primary safety and efficacy analysis was done on the intent to treat population with an alpha set at 0.05. It was determined that a sample size of 510 patients per treatment group completing 36 weeks of the study would provide at least 80% power to demonstrate superiority of dulaglutide 3 milligrams and or 4.5 milligrams compared to 1.5 milligrams in change from baseline and mean HbA1c levels. Power was met as each treatment group had more than 510 participants that completed 36 weeks of the trial. The percent change in HbA1c from baseline to 36 weeks was ratio data, and an ANCOVA model was used to analyze the data, and which was appropriate for this data. The change from baseline in body weight to 36 weeks was also ratio data using an ANCOVA model, which was appropriate to analyze this data. And then the proportion of patients achieving an HbA1c target of less than 7% was also ratio data. The statistical test that was used was a logistic regression, which was appropriate for this data. As for the results, at 36 weeks, there was an observed difference in the primary efficacy measure of percent change in HbA1c from baseline between the dulaglutide 4.5 milligram group with a reduction of 1.77% compared to the dulaglutide 1.5 milligram group with a reduction of 1.54%. It was found that the 4.5 milligram dose was superior over the 1.5 milligram dose with an estimated treatment difference of 0.24% and a p-value of less than 0.001. However, superiority was not found with the 3 milligram dose over the 1.5 milligram dose with an estimated treatment difference of 0.10% and a p-value equal to 0.096. At 36 weeks, there was an observed difference in the secondary efficacy measure of patients reaching an HbA1c level of less than 7% in the 4.5 milligram dulaglutide group compared with the dulaglutide 1.5 milligram group with an odds ratio of 2.2 and a p-value of less than 0.001. At 36 weeks, there was an observed difference in the secondary efficacy measure of body weight from baseline between the dulaglutide 4.5 milligram group with a decrease in body weight of 4.6 kilograms compared with the 1.5 milligram group with a decrease in body weight of 3 kilograms and a p-value of less than 0.001. At the conclusion of the study, the most commonly reported adverse effects were nausea, diarrhea, and vomiting, and the incidence of each was numerically higher in the higher dulaglutide dose groups compared with the 1.5 milligram group. These adverse GI events most commonly occurred early and abated over time. The incidence of study drug discontinuation due to common GI effects was relatively low, but more common in the higher dose groups than the 1.5 milligram group. The incidence of more severe adverse events, such as hypoglycemia, was more common in the 1.5 milligram group at a rate of 1.3% than in the 3 milligram group, which had a rate of 0.3%, and the 4.5 milligram group, which had a rate of 1.1%. There were 3 deaths in the 1.5 milligram group and 4 deaths in both the 3 milligram and the 4.5 milligram group. For the author's conclusion, and based on the results, it is reasonable to say that escalating patients from a 1.5 milligram dose of dulaglutide to either a 3 milligram or a 4.5 milligram dose is beneficial to glycemic control and reduction of body weight after 36 weeks of treatment. Furthermore, the results were maintained at 52 weeks, so this further proves the benefit of dose escalation. For strengths of the study, power was set and met, the biostatistical tests were appropriate, the outcome measure was valid, inclusion and exclusion criteria were adequate, randomization resulted in similar groups, the length of the study was appropriate, the treatment regimen was appropriate, the blinding was appropriate, and the author's conclusions were supported by the results. For limitations, recruitment methods were not discussed, compliance bias was present, concurrent drug use was allowed, and steps were not taken to decrease inter-rater variability. This was level of evidence was a level 1 with minor limitations. For my recommendation, I would recommend once weekly administration of either subcutaneous 3 milligram or 4.5 milligram dulaglutide to be used for 52 weeks over 1.5 milligram dulaglutide in the treatment of patients with type 2 diabetes that have been treated with metformin, have not met the HbA1c target, and have a BMI of greater than or equal to 25 kilograms per meter squared for the following reasons. The first being efficacy. This was a well-designed phase 3 trial that showed patients with type 2 diabetes who were not controlled on metformin would benefit from dose escalation from dulaglutide 1.5 milligrams to either dulaglutide 3 milligrams or 4.5 milligrams, as these doses provided clinically relevant dose-related reductions in HbA1c and body weight. At 36 weeks, 4.5 milligram dulaglutide improved the HbA1c levels more significantly than 1.5 milligrams, and there was an estimated treatment difference of 0.34% with a p-value of less than 0.001. At 36 weeks, the 3 milligram dulaglutide also improved the HbA1c levels more significantly than 1.5 milligrams, and there was an estimated treatment difference of 0.17% with a p-value of less than 0.001. It was also found that dulaglutide 4.5 milligrams was superior to 1.5 milligrams dulaglutide for reduction in body weight with an estimated treatment difference of 1.6 kilograms and a p-value of less than 0.001. For safety, overall, dulaglutide was well tolerated among dose groups, as the most common adverse events reported were nausea and vomiting, with the incidence of each being directly related to the strength of the dose, but however, it was reported that these adverse events abated over time. As for cost, the cost of one solution pen injector of Trulicity subcutaneous of any strength, 0.75 milligrams, 1.5 milligrams, 3 milligrams, and 4.5 milligrams per 0.5 mLs is $253.31 per LexiCount, and a 1 month supply is totaled at $1,013.24. For special considerations in populations, dulaglutide has been shown to increase the incidence of thyroid C cell adenomas based on dose and treatment duration. Therefore, dulaglutide is contraindicated in patients with a personal or family history of medullary thyroid cancer, and patients starting on dulaglutide should be counseled on the potential risks of using dulaglutide. I would like to thank you for listening to my presentation on dulaglutide. And if you have any questions, please feel free to reach out and email me at sobusn05@dyc.edu. Thank you.